Simi, and I'm Senior Clinical Editor at BMJ India. Thank you so much for joining the webinar today on diabetes and COVID. BMJ would be conducted webinars at regular interval on clinical topics like renal disease and COVID-19, palliative care in COVID-19 era, and also would be conducted webinar on how to write case reports for early startups, students, how to develop research question, and other associated topics as well. The aim of this activity is to update your knowledge, enhance your daily practice, and improve the quality of care that you provide to your patients. With this, now let us begin the first webinar, our panel for today, which will focus on the overview of diabetes and COVID-19, use of OHAs in patients with diabetes and COVID-19, and last, but a very interesting piece would be to know the controversies revolving around the COVID-19 in diabetes. We would be addressing your questions at the end of the session, so we'll request you to write your questions and post it to us along with your name and city. That will help us, and we'll try our best to address all your questions. For today, our distinguished expert panel includes Dr. Ritesh Gupta, Additional Director, Fortis CDOC, Dr. Amrita Ghosh, Attending Consultant, Fortis CDOC. And we'd like to start the session, and I'm so pleased to welcome Dr. Anoop Misra, a very special guest. Dr. Misra doesn't need any introduction. He's the chairman at Fortis CDOC, Center for Excellence in Diabetes and Metabolic Diseases and Endocrinology. He's the recipient of Padma Shri and Dr. B.C. Roy Award. Over to you, sir.
Thank you. Thank you, Simi. And I thank BMJ for arranging for this very interesting session, because this is the topic of the day, COVID-19. It is surging all over India, but maybe we are in Delhi a little fortunate where it is leveling off. I welcome people from all over India, and I see a lot of people from other countries as well. Pakistan, I know a couple of people, so welcome. And I hope me and my colleagues will be able to tell you something new as far as COVID-19 and diabetes is concerned. Now, three of us will tackle three sessions. Number one, general overview will be tackled by me, and then subsequently, the anti-diabetic agents in COVID-19 will be tackled by Dr. Ritesh Gupta, and then controversies by Dr. Amrita Ghosh. So this is the overall program. First 10 minutes is mine. Now, we have written a lot about COVID-19 and diabetes. We have almost 32 publications in the last 4 months. On the top is the international conferences, which I was fortunate to be part of. And then global call to reconnect with patients, editorial, which I wrote with Dr. Bloomgarden, and number of publications from my colleague, Dr. Ritesh Gupta and Dr. Amrita Ghosh. On the right side is the first publication of COVID-19 and diabetes anywhere in the world from our group. And this has been quoted more than 100 times now. A macro view, that is my job, to tell you about overview of diabetes and COVID-19. There is no doubt that the coronavirus is a bad omen for patients with diabetes. In this particular slide, which we published some time back, this is data compiled from various studies in China and then subsequently USA. The data are from patients who were admitted in the hospital who were not severe, and proportion of patients with diabetes. And you can see the bars, tall bars here, which are proportion of severe cases, amongst which diabetic patients. So 17% out of 100 of severe cases were diabetic, and so on. And lastly, you see in USA, almost 32% of severely affected patients with COVID-19 were diabetic. While the patients which are not severe, the proportion was not very much. So What is the meaning of that? Meaning is that diabetic patients are getting severe COVID infection, and that may cause more morbidity and mortality. Now, coming to mortality, of course, the risk for mortality will depend on the geographical region and population characteristics. In some countries, it is more, for example, US, Italy, and so on. And countries like India, it is far less than other countries. Now, what are the factors which increase mortality? Cardiovascular disease, diabetes is number two, high blood pressure, and then respiratory diseases and cancer. Now, diabetes is everywhere. Whichever data you choose, whichever publication you choose, diabetes remains amongst number one or number two causes of severe cases. Of course, it will attack those with a higher age group, and here you can see the moment a person turns 60, the proportion of severe patients or a mortality with COVID-19 is 3 times, and then another 3 times, and so on. So every decade it is increasing by 2 to 3 times. So 60 years is something which is the where we can put a line there, and if patient has comorbid diseases, he at a higher risk. Now, what has happened over a period of time when lockdown was in place in India? What happened to the diabetic patients? Did they get worse? Now, this is our mathematical model. My colleagues in Calcutta, we published this data. And based on the previous data from various other disasters, we predicted that A1C will increase precipitously in 30 and 45 days, and also various complications which include microvascular complications as well as macrovascular complications will increase. This is our prediction. So the diabetic patients will be worse off. I'll show a couple of, one more slide on actual data and what is happening to our patients later on also. So our patients will be worse off, or maybe patients anywhere will be worse off. If they are worse off, what happens to the diabetic patient who has uncontrolled hyperglycemia? Now, this is a very good study. 500 patients, 250 well controlled and 250 poorly controlled. And percentage survival has been calculated over 28 days. You can see the survival of poorly controlled diabetics is pretty bad. It's significantly less than well-controlled diabetes. And also complications. If you look at on the right side, septic shock, ARDS, DIC, acute kidney injury, acute heart injury is much less in patients who are well controlled. And if you take ARDS as one complication, then there's a 50% decreased risk of ARDS in patients with good control versus the bad control. So patients have to have a good control to actually weather the storm of COVID-19. What happens to the patients who are apparently non-diabetic? And we calculated their risk for developing diabetes based on their lifestyle habits and weight gain. And you can see 40% of the people who are apparently non-diabetic actually gained weight, and 16% gained 2 to 5 kg of weight. When all parameters were analyzed and put on the risk prediction engine, then there was 7% increased risk of diabetic in apparently non-diabetic individuals during this time. That means non-diabetic individuals may have a high sugar already occurring. So what is the meaning of that? There are two meanings. One, that they should get tested. All non-diabetic individuals above 30 years in India, we are testing. And second, they may also have higher risk of COVID-19 mortality. Now, this particular paper, an excellent paper, showed fasting blood glucose is independent predictor of 28 days mortality in patients without previous history of diagnosis of diabetes. Now, our patients, we have predicted that those who did not have diabetes will have diabetes. So people are at risk, especially those who are obese. You see at the top is the cumulative mortality in patients who even have slightly high sugar, more than 7 millimole. A hazard ratio is 2.30, and in hospital complication hazard ratio is even more. So diabetics have to take care more, and non-diabetics also have to see whether they are number one diabetic or not, and number two, their problems may occur if their sugar is high during the hospitalization with COVID-19. Now, obesity is behind that, and we have shown you 40% of the people actually gain weight, and some people gain much more weight. We have the max weight gain around 7 to 8 kg. Now, besides comorbidities in obesity and metabolic risks like diabetes and so on, respiratory dysfunction may play a good role as far as the respiratory complication of COVID-19 is concerned, and this must be kept in mind. So obesity is a risk factor for severe course of COVID-19. Now, why should a diabetic patient more often develop a problem with COVID-19? Number of factors: impaired T cell function, in general impaired immunity, increase in interleukin 6, and you by now know that interleukin 6 is one of the central factors for cytokine storm in COVID-19 infection. So the cytokine storm may be more as far as diabetic is concerned. Compromised cardiac and lung function, and there are some theoretical other factors like increase in the one factor called furic, which is involved in entry of coronavirus into cells, and which may be more so in diabetics, and maybe increase in ACE level, which my colleague will talk about a little later. Now, factors associated with increase in hyperglycemia or hypoglycemia during COVID-19 infection patients with diabetes, increase in the insulin resistance occurs in most of these patients, and viral sepsis, which increases insulin resistance and may increase blood sugar. Some of them have very, very high blood sugar, very difficult to control diabetes. Use of corticosteroid and some other drugs also, Dr. Ritesh will show you. And since beta cells have a receptor for ACE2 through which virus will enter, the beta cell infection or dysfunction or destruction may cause new onset diabetes and may be ketoacidosis. In addition, hypoglycemia may also occur because of vomiting, diarrhea, poor oral intake, and also use of hydroxychloroquine. Now, what is the situation analysis in India? I'm not going to show you charts and diagrams and so on, but from diabetes point of view, you can see on the right side is the prevalence of diabetes as per the decades in Southeast Asia, which means India, Pakistan, all of us together. The max diabetes prevalence is between 50 to 70 years of age, and this is where COVID-19 is striking. Elderly population is very, very high with diabetes in India. Interestingly, majority of COVID-19 cases in India are less than 40 years of age. You can see here an early analysis, but attack rate per 100,000 is highest in around 6 decades, where diabetes is also high. So this is the sort of convergence between diabetes and COVID-19 epidemic. This is one of our studies, which also shows what I told you earlier. This was done, and so after 71 days of lockdown, an online survey which showed that habits have gone bad. Most of the habits, but some are good also. And these habits have led to weight gain, which I showed you earlier. 20 to 40% of people gain weight. So diet, there was an increase in the carbohydrate intake, increased snacking, but a good part is increased fruit intake and major decrease in the ordering food from outside. Of course, all the shops are closed. The decreased exercise duration in 50% of the patients. In this study, weight gain in 20%, widespread mental stress. But in Delhi, there was a good availability of medicines. And when we asked them, they were willing for teleconsultation and they had knowledge of that. So some good points and some bad points. Now, this is my last slide, and this is a hypothetical slide, which I show you what lies in future for diabetes and COVID-19 as far as India is concerned. And maybe that is true for other countries as well. This is a slide which is made by Harpreet Bajaj, my colleague from Canada. Orange is the COVID deaths or hospitalization. First wave is right here. Second wave possible in 2021 and smaller waves in subsequent years. And the yellow one is the diabetes related acute care disruptions and then leading to death or hospitalization. Here is after first wave, here is after second wave, and here is a chronic care interruption. Now, uh, I told you the mortality in India, whatever may be the reason, is lesser than other countries. So this first wave mortality and hospitalization may be lower in India than in other countries. And same may be there for the second wave. But diabetes care, now baseline diabetes, A1C and the fasting blood sugar, blood pressure, etc., all vastly uncontrolled in Indian population. And further acute care interruption will lead to more mortality. So this may be more. Diabetes care interruption leading to more mortality subsequent to COVID-19 peaks, and then chronic diabetes care interruption will lead to more problems. So diabetes mortality may be more, COVID mortality may be less. What it ultimately leads to, we do not know, but this is what we visualize will be in the future. So with that, I finish my presentation and and then invite. Let me unshare the slides. Okay. Let me invite Dr. Ritesh Gupta, who will carry on the discussion and give you an interesting point of view as far as anti-hyperglycemic drugs in COVID-19 is concerned. Thank you.
Thank you, sir. Uh, so after this brief macro view and overview, let's see how we can manage patients with diabetes in this COVID era and how we can manage patients who have diabetes and COVID, both the conditions. So now some of the basic principles, how we manage diabetes, especially the home care for patients with diabetes in the current times. The first thing, of course, is, as with everyone, minimize exposure. All measures which are there all over the media have to be implemented. Barriers, masks, all the precautions, distancing is important. And of course, use of telemedicine for consultation, though there are some problems, some pitfalls, but yes, it should be utilized for patients who cannot come. Now, shelter at home self-care. So if there is restricted movement, then what can you do? You can exercise within confined spaces. Resistance exercises can be undertaken. Diet has to be given attention to. Citrus fruits, for whatever vitamin C is worth, there's no harm in taking citrus fruits, green leafy vegetables, proteins, legumes, nuts, plenty of sunshine. There is some role of vitamin D. And one should avoid intermittent fasting and keto diets because they can have some complications which we don't want to land up with in this time. And self-monitoring is important, very important to check glucose, blood pressure, and for type 1 diabetic patients, ketones should be checked regularly. And medication compliance is important, so one should ensure extra supply for at least 30 days. And hydration is important, especially if there is pronounced hyperglycemia or if the patient is on SGLT2 inhibitors or diuretics, etc. But there are certain conditions in which patient needs urgent help. When there is marked increase in blood glucose values, there are ketones in urine, any infection, foot infection especially, pregnancy, any abscess, acute abdominal problem, etc. All these conditions would necessitate a visit to the hospital and medical advice. Now, what do you do if there is a diabetic patient with COVID-19? The general principle is that we should maintain blood glucose under control, good control, and hope that COVID-19 severity is lesser. As Dr. Misra showed you the slide that with the sugar control, the complications are much better. All non-diabetic persons with COVID-19 should be checked for diabetes in the beginning, as we know that, as you saw in the slides, that there will be many new onset diabetes and even fasting hyperglycemia in patients who are not known to be diabetic is related to mortality. And so sugar should be checked. Now, if the infection is mild, if it's a homebound patient, most patients with normal oral intake can continue with their usual anti-hyperglycemic medications with an advice to monitor sugars at home and report to the doctor. Now, if it's a moderate disease, patient could be at home or in the hospital. In most patients, we would discontinue SGLT2 inhibitors because the risk of dehydration and euglycemic ketosis. Similarly, GLP-1 receptor agonist would also be discontinued. And metformin, though it is useful, it has many benefits as we will see later, but it may also need to be stopped if there is vomiting or poor oral intake. Now, insulin should be used in sick patients that might need a visit to the hospital or even hospitalization. But if patient is unable to tolerate other drugs, insulin will have to be used. Now, what happens if there is a severe infection during hospital stay? Now, reasonable blood glucose goal is 110 to 180 milligram per deciliter. Now, there could be some issues with glucose monitoring. One is that you need to minimize contact. So one can advise the patient for self-monitoring. The patient can monitor sugars and inform on phone. There is a problem. Some of the ICUs are using high doses of vitamin C to prevent bronchoconstriction and other effects. And that can give factitiously high blood glucose readings with the glucose strips. So one may need to check plasma glucose in that setting. Now, CGM, continuous glucose monitoring, is promising because it obviates the contact. However, there is interference with paracetamol and also salbutamol, which is a frequent drug in these patients. And also with hypoxia, the reliability goes down. Now, insulin regimen. Well, the ideal insulin regimen is IV infusion in a sick patient, as we use in all patients. But again, that increases contact of healthcare worker. So what can we use? There are some alternative strategies like basal insulin and bolus doses every 4 to 6 hours. You can give one shot of basal insulin and then bolus every 4 to 6 hours. The age-old split mix regime, the regular and NPH insulin twice a day could also be tried. Insulin pump is good only if the expertise is available. Now let's come to anti-hyperglycemic drugs. Do they have any effect on COVID-19 per se? Now, before that, let's come to this important diagram. Now, we all know angiotensin 1 gets converted to angiotensin converting enzyme, and then angiotensin 2 acts on angiotensin 2 type 1 receptor. Now, this angiotensin 2, apart from its other vascular effects, is also implicated in acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. It increases vascular permeability, etc. Now, why this interest in renin-angiotensin system? Because the virus, the SARS coronavirus 2, has as its receptor ACE2. ACE2 is the receptor for this virus. And this, once you use ACE inhibitors or ARBs, as Dr. Amrita Ghosh is going to talk later, there is increase in ACE2 production. This increased ACE2 levels would increase virus entry in cells, though that has never been demonstrated, but we presume that it would happen so. And once the virus enters the cell, it actually down-regulates the ACE2. And ACE2 actually is a protective factor for lung and heart. So on one hand, ACE2 on the cell surface is acting as a receptor for SARS coronavirus 2. On the other hand, increased ACE2 is also protective for lung and heart. So we'll try to understand the effect of various anti-hyperglycemic drugs based on this mechanism. So what about metformin? Metformin is a pleiotropic drug, has so many effects, so many mechanisms of benefit. So one is that it also increases expression of ACE2, and it leads to some conformational changes in ACE2, which could reduce the binding of virus with ACE2. The most important effect of metformin is that it decreases the release of pro-inflammatory cytokines like IL-6 and TNF-alpha, and it increases the release of anti-inflammatory cytokine like IL-10. It also improves neutrophil to lymphocyte ratio. So all these factors are of benefit. And there are some other factors also which are less well categorized, like inhibition of mast cell activation, and mast cell activation is considered to be the first step towards cytokine storm. And decreased thrombosis, improved endothelial function. So all these factors provide some mechanistic basis of benefit of metformin in COVID-19. This was a study from Wuhan in which about 283 patients who were hospitalized with COVID-19. They did an analysis, and what they found was, though the hospitalization time in the metformin group and in the non-metformin group was not different, the in-hospital mortality was significantly better in patients who received metformin. A similar effect was seen in a much larger analysis of a database from United States. This included patients with COVID-19 and diabetes, more than 6,000 patients from all 50 states of United States. And this was an insurance database, and persons in the metformin group had more than 90 days of metformin claims in the 12 months before hospitalization. And this is what they found. Interesting results. While in men, there was no effect of metformin, in women, the survival was much better, significantly better in women who received metformin. Now, the reason for that is not very clear, but one reason is that the anti-inflammatory effect of metformin, especially the effect on IL-6 and TNF-alpha, is much more seen in females in animal studies than in males. So that could be responsible for this gender differentiation in the effect of metformin. Now, what about sulfonylureas? They're effective drugs, very effective. Now, they have no reported effect on ACE2 levels. There are no studies in COVID-19. There is some report of tolbutamide causing reduction in pneumocystis carinii pneumonia. It's an old drug. But of course, the usual concerns with sulfonylureas about their prolonged action, about hypoglycemia, unpredictability, probably they are not the best drugs to use in anything more than a mild disease. Now, what about DPP-4 inhibitors? Now, DPP-4 is an interesting molecule. It's a receptor for the Middle East respiratory syndrome coronavirus. Possibility of SARS coronavirus 2 utilizing DPP-4 also cannot be ruled out. Also, DPP-4 is identical to CD26 on lymphocyte surface, is involved in immune response. We know that nasopharyngitis was listed as a side effect when DPP-4 molecules were first launched, though the later analyses have not shown any adverse effect on immunity with these molecules. There is no effect, there is no study in COVID-19, and their exact role is not very clear. Now, what about pioglitazone? Pioglitazone also increases ACE2 expression by downregulating an enzyme called ADAM17. It's an ACE2 cleaving enzyme. So it inhibits that enzyme, thereby it increases the ACE2 expression. Also, there is reduction in pro-inflammatory cytokines like IL-1 beta, IL-6, TNF-alpha, IL-8, etc. By its action on nuclear factor kappa B. So this is all good, but also there are some harmful effects reported. In previous studies, there is increased risk of pneumonia which was reported with pioglitazone. In a Spanish database, a large database, the odds ratio was 2.48 with pioglitazone. And in a recent meta-analysis, it was about 1.4. And of course, there is propensity to cause fluid retention, heart failure. So in any sick patient, this would be best avoided. There are no studies in COVID-19 till now. Now, what about SGLT2 inhibitors? Now, they also have been shown to have an indirect effect on ACE2, especially if they are used along with ACE inhibitors. They have another mechanism by which they can affect the viral entry into the cell and viral replication. So SGLT2 inhibitors, they cause mild ketosis, by which the fuel efficiency of the cell increases. And there is reduction in oxygen demand, which leads to decreased lactate production and increase in the pH of the cytosol. And that can reduce viral entry into the cell, in the same way as chloroquine is supposed to act. But of course, there is caution about dehydration and the possibility of euglycemic ketoacidosis. There is a trial, DARE-19, dapagliflozin in respiratory failure in patients with COVID-19. This trial is ongoing in moderate to severe patients with COVID-19 who are not on mechanical ventilation. The sample size is about 900. It is expected to be completed in December this year. Now, GLP-1 agonists also have been shown to increase ACE2 expression in lungs and heart. There is experimental evidence of benefit of liraglutide in acute lung injury. However, there are no reports in COVID-19, but in most patients, nausea, vomiting, and other GI side effects are limiting factors in use in sick patients. Now, what about insulin? Insulin is the gold standard. It's the treatment of choice in hospitalized patients with COVID-19, as we discussed. Of course, there are concerns about exposure to healthcare worker, and that also we discussed: self-monitoring, CGM, insulin pump, basal bolus regimen instead of IV infusion. All those things can be used. But there is one interesting data. This was a study from Wuhan again, and 84 patients with diabetes. And this is what they found, that patients who required insulin, they had a poor survival compared to those who did not require insulin. Of course, this could be simply because insulin was given to patients who were very sick, but this is anyway an interesting study. And so insulin, interestingly, has also been shown to increase ACE2 expression by attenuating the effect of the same ADAM17, the ACE2 cleaving enzyme. So the exact clinical effect of these is not very clear. So to summarize the effect of various anti-hyperglycemic agents, so most of the agents have shown some effect on ACE2 in terms of increase in ACE2 expression, except DPP4 inhibitors and sulfonylureas. Now, there is preclinical evidence of anti-inflammatory effect in lung injury models. That also is there in for most of the drugs, except SGLT2 inhibitors. Now, what about the clinical evidence? The clinical evidence is there only for Metformin, as we discussed those two studies in which Metformin users had a lower mortality. Now, some of the emerging issues in hospitalized patients with diabetes and COVID-19. There are some issues which people have seen. There is high risk for ketoacidosis, more in patients who are on SGLT2 inhibitors. Also, there are some newly diagnosed patients and some present with ketoacidosis, as was discussed. There are beta cell, there are ACE2 receptors on beta cells, and that is how this viral infection can lead to new onset diabetes. And also, there are mixed hyperosmolar and ketoacidosis states. One needs to manage fluid requirement very judiciously because there is myocardial compromise, there is leaky lung, so one needs to be careful about fluids. And some patients have very significant insulin resistance, probably because of increased cytokines, and they require very, very high doses of insulin. So these all things have to be kept in mind while treating these patients. Now, what about the other drugs? Now, statins, which are commonly prescribed in patients with diabetes. Now, they are known to inhibit nuclear factor kappa B. They might help in blunting the cytokine storm. There are various other mechanisms by which statins can work, and there could be some role of statins there. Calcium channel blockers also have been shown to reduce severity of disease and mortality in patients with pneumonia, presumably by inhibiting calcium influx into cells. There is no reported role in COVID-19, but there are hypotheses and mechanistic possibilities. Now, aspirin with underlying coronary artery disease, it needs to be continued as antiplatelet agent unless otherwise contraindicated. So with that, I'll finish and I'll stop sharing. I'll invite Dr. Amrita Ghosh to start her slides.
Thank you, Ritesh. We come to the last part of the presentation. Amrita will touch upon a couple of controversies in management of COVID-19 as far as diabetes and related diseases concerned. Amrita.
Yeah, thank you. So my topic is very controversial. So, and a lot of confusion around if we should use this molecule or we should not use this molecule. So I'm here to clear a few doubts. So first we'll touch upon ACE inhibitors. So Dr. Ritesh has already explained you this slide, but how does this come into action? So ACE inhibitor here inhibits the conversion of angiotensin 1 to angiotensin 2, and ARB works here. Okay, and there's another pathway in which if this is blocked, angiotensin 2 makes angiotensin 1,7. So in when you use ACE inhibitors and ARB, so there's an increase ACE2 and ACE ratio, and there's increase angiotensin 1,7. So what is the implication? So the potential harm can be increased risk of viral attachment, because as Dr. Ritesh explained, that ACE2 is the point of attachment where the virus get attached. So this is increased, so it can increase the risk of viral attachment. Reduction in the cytosolic pH, that's the main thing, and increased central sympathetic activity. So these are the potential harms, but this molecule has potential benefit, and these are vasodilatory effects, antifibratic effects, lung protection, which was seen in Ebola virus infection, which was treated with losartan, and benefits of recombinant ACE2 in ARDS. And in future there might be studies coming with ACE2, recombinant ACE2, as a potential therapy of COVID also. So if we come to the clinical evidence, so these are a few studies which study the usage of ACE or ARBs in patient. The first 3 studies was done in the eastern part of the world, in China and South Korea, and they found that there's no effect of ACE-ARB on the severity or mortality. Then a study was done in US with almost around 5,700 patients, which showed that there's an increased mortality in users of ACE and ARBs, and the mortality with ACE was somewhere around 30% and ARB was 32%. Then again, a study from China with almost 1,000 patients showed that there's a reduced mortality in users of ACE-ARBs, and a very recently published trial from Spain showed that there's reduced hospitalization with ARB. So here it's a mixed slide here. So what do you have to do? You do not have to stop ACE or ARBs in your patient with COVID. Then moving on to controversies, chloroquine and HCQ treatment. So hydroxychloroquine and chloroquine uses prior to COVID was basically for rheumatoid arthritis, SLE, malaria, amoebiasis, and even diabetes. And the hydroxyl moiety added to the chloroquine, basically it reduces the entry through the blood-brain barrier. Otherwise, the effects are similar. And these drugs have been studied for various viral infection previously. So there have been few effective studies and ineffective studies also. So in vitro, effective studies showed that it has good effect. The molecule has good effect on human coronavirus, OC43, enterovirus, Zika virus, and influenza A, H5N1. And in vivo, it was useful in hepatitis C. Then ineffective was in dengue, and it was shown that in chikungunya, there was an increased viral replication. So ineffectiveness of these molecules in viral infection could be because of poor concentration of chloroquine in the target tissue. So the concentration of chloroquine for any antiviral effects, because this is a basically anti-malarial drug. So for any antiviral effect, it is about 3 times higher than the necessary to inhibit malaria parasite. So that is the point to be taken. Moving on to the mechanism of chloroquine. So for that, you need to first understand this slide. So this is the virus, it enters through endocytosis, and basically due to the acidic pH of the lysosome, and then this is transported, and then there's a virus uncoating of the envelope is uncoated, and then there's replication of the viral nucleic acid, and then by the post-translational processing, the envelope of glycoprotein is produced, and then the virus is assembled, and through exocytosis, it is released out. So how does chloroquine work in this scenario? First of all, chloroquine increases the pH of lysosome, and it causes the interference of the virus through endocytosis. So it is blocked here. Then it prevents the virus uncoating. And thirdly, it prevents the post-translational processing of envelope glycoprotein. And in addition to this, chloroquine has immunomodulatory properties, may help in suppressing cytokine storm. Now moving on to the studies of HCQ and CQ. So a few studies which was done in the early duration of the disease, like in March or something, early Feb or March. So it was very enthusiastic studies which shared that there's a reduction in viral load and reduction in the need for ICU stay. Though these studies were very small studies, and then a few data came that there's no significant improvement in HCQ group. Then WHO was doing this study called as Solidarity, and they, after a study which was published in Lancet, they stopped the ongoing trial. They stopped the ongoing trial, and after that, there's a trial which was called as Recovery Trial, which was done in UK, was also stopped after the interim data because there was no significant benefit in 28-day mortality, or there was no significant benefit in the length and the decrease in the length of hospital stay. Very recently, in July, the study was published from US. It was Henry Ford study, which was a multi-center retrospective observational study. And this study has shown that there's a 66% reduction in the severity of the disease. And when compared with HCQ and azithromycin, there was a 70% reduction in disease. The basic problem with the usage of HCQ is the prolongation of QT interval. So now the guidelines is that if the QT interval is more than 500 seconds, this molecule should not be used. And if you're using, you should use with proper ECG monitoring of the patient. So talking about the other drug treatment, as these are the drug which is available for the COVID management. And amongst this chloroquine, you can see there is an improved glucose profile, and it improves lipid profile in patients with diabetes. And when we compare with other ongoing molecules which is used, corticosteroid definitely increases glycemia, and it increases dyslipidemia also in the form of increased TC and LDL and TG. And other molecule like remdesivir, tocilizumab, and favipiravir has no effect on the molecule. No effect on, glucose and lipid. So moving on to prophylaxis of HCQ. So early in March, the National Task Force for COVID-19 empirically recommended the usage of HCQ in India, and it was told that in asymptomatic healthcare workers who are treating suspected or confirmed COVID-19 cases, they should be given prophylactic dose, and the dose was 400 mg twice daily on first day, and followed by 400 mg once daily, weekly for once a week for 7 days. Then for asymptomatic household contacts or of confirmed COVID-19 patients, the dose was 400 mg twice daily on first day, followed by 400 mg once a week for 3 weeks. So on this guidelines, there was a study done by ICMR for healthcare workers, and to see what is the usage of HCQs in those healthcare workers. This was a case control trial, and 624 case and 529 control. And it was seen that consumption of 4 or more maintenance dose of HCQ was associated with a significant decline in getting the disease. So here you can see in the graph here that this is the first 3 dosage, and as soon as there's a steep decline after 4th or 5th dosage of weekly dosage of HCQ. And this dose response relationship existed between frequency of exposure to HCQ and such reductions. So coming on to the third controversy, which is proton pump inhibitors. So first you have to understand what is the mechanism of diarrhea, as we have been seeing a lot of enteritis along as a symptom of COVID-19. So again, there's a role of ACE2 receptor induce diarrhea, because that ACE2 receptors are present in gastric cells. And then the cytokine storm, with an increase in cytokine level, can alter, all these cytokines can alter the gut and brain axis. And the composition of the gut flora can be altered because of the increased pro-inflammatory cytokines. And in patients with inflammatory bowel disease, the ACE2 receptors are overexpressed in inflamed tissue. These are the putative mechanisms. So recently there was a study which says that proton pump inhibitor is tied to COVID risk. So this was a population-based online study which was done in US for the duration of 1.5 months, and it had almost like 53,000 participants. On almost like 3,000 participants were reported to have COVID positive. And this study showed that usage of proton pump inhibitor once a day were twice likely to have COVID-19, positive COVID-19 report. The odds ratio was 2.15, and usage of PPE twice a day were almost 4 times likely to have positive for the disease. And usage of H2 blocker drug basically once daily were having 15% less likely to report COVID positivity. So so this study brought to us that usage of PPE should be used in caution with patients with COVID. And in case of if you want to reduce the acidity in your patient, if you want to use some kind of antacids or something like that, you should use H2 blockers. So I finish my slide now. Thank you.
Thank you, Amrita. Please stop sharing your screen. Yeah, thank you. So we have yes, Simi is indicating that attendees have posted their questions. We have I've already kept track of that, and I have read almost every question. I've selected a couple of questions. We cannot answer everything. So first question is to Dr. Ritesh. And there are a couple of questions actually related. One is that new onset diabetes in COVID-19 patient, and whether beta cell destruction is actually predominant, or insulin resistance is predominant, or both are occurring. Can you answer that?
Right, sir. So so as pointed out, that there are ACE2 receptors present in the beta cells. That is known. And in the previous SARS epidemic, it was found that there was new onset diabetes occurring with after this infection. So that is one part. So that is one possibility which is there and which is happening. We are seeing the patients are being reported with the ketoacidosis. So that means there is beta cell destruction. Also, with the surge in cytokines, the cytokine storm, all these things can also lead to insulin resistance. So the high insulin requirement of some of the patients who are admitted with COVID-19 and diabetes in ICU could be contributed to by increased insulin resistance. So probably there are both factors which are working. One needs to actually see later what really is the case. There may be different factors working in different patients.
Okay, thank you, Ritesh. And second question, which is often asked, is what kind of diet we should give. Of course, it has to be individualized. Diet has to be individualized. One clear diktat is that please do not use any diet which is very low calorie, or a fat diet, or keto diet, or intermittent fasting during this time, because we want your nutrition to be maintained and you want micronutrient deficiencies not to occur. And we have prepared a diet chart, and any of you, if you want, you can email us, where we have it right here, where we have put certain diets which can yield more vitamins. Vitamins like zinc, vitamins like vitamin C, vitamins like vitamin E, and for just to give you an example of vitamin or zinc in the food, pumpkin seeds, flax seeds, chia seeds, cashews, almonds, rajma, chole. These have good amount of zinc. So apart, some people are giving external zinc, and these are good for zinc. So the diets have to be chosen with lots of vitamin, lots of fruits and vegetables. You know, usual diktat is 5 servings of fruits and vegetables, but now WHO during this time has said 8 to 9 servings of fruits and vegetables. This is what we should take. So please have individualized diet plan for your patient, but incorporate all these. Now, third thing is the one question which is very interesting is uh, whether insulin treatment here would worsen diabetic retinopathy. Now, it is known from DCCT study that sudden drop of blood pressure, blood sugar in a patient previously uncontrolled, and then the drop is maintained, may lead to worsening of diabetic retinopathy. That occurred with insulin in DCCT study, and that has occurred with semaglutide in some of the recent studies. So it is a possibility if a patient is totally uncontrolled and we control it very well during the hospitalization, then it may worsen. That is something which is not of a great concern at this point of time when we have to save the life of the patient. Ritesh, there is a question about sudden death. Why should a sudden death be occurred? Patient is okay 1 or 2 hours before, and then suddenly patient drops down. So is there a mechanism? Can you?
So sudden death could occur. Sudden death, patients who are sick, of course, can have sudden arrhythmias, and they are getting so many drugs. We have talked about QT prolongation. So of course, and these patients are also prone to develop thrombosis. So a stroke is reported as a important cause of death in these patients. I'm not aware of any study to correlating diabetes with sudden death in these patients, but yes, stroke and arrhythmias would be the main contributing factors.
Yeah, there is a happy hypoxia also. Patients' oxygen level dropping down dangerously low, and still patient is okay, and suddenly he goes down. So there is something else occurring, some other mechanism occurring where the oxygen saturation drops down, and it doesn't, sort of manifest in the same way as in other diseases. That is number one. And so one is sudden death due to COVID-19. And what is also important to know that sudden death outside in the community, which is occurring, a lot of sudden deaths are occurring because the patient with coronary artery disease are not being taken care of, or the patient with diabetes are not being taken care of, and they are dying at home. So more out of hospital cardiac arrest are occurring. So both things are there in this thing and outside because of certain factors. Now, I have a question from Dr. Wali. Dr. Wali, thank you for joining. He's a Padma Shri awardee and a very, very distinguished physician to several prime ministers and presidents. Dr. Wali, thank you for coming here. He has asked a very pertinent question. One, all obese or lean diabetics have the same risk. Dr. Wali, nobody has actually looked at this problem. But I personally feel those diabetics who are obese or lean, who are very fit, they have been exercising regularly, watching their diet regularly, their sugar is controlled, their blood pressure is controlled, their lipids are controlled, they don't have any heart problem, they are not smokers, they are going to certainly do much better than the same weight diabetes who has multiple problems. So weight actually will count, certainly, but if a person is fat and fit, is likely to evade coronavirus, and his or her system is going to fight coronavirus. Dr. Wali has also written about antioxidants and so on. Dr. Wali, I have answered this question that antioxidants and several other vitamins will be available if we take lots of fruits and vegetables, and we have made a diet chart full of fruits and vegetables which can help these patients get more antioxidants. Now, so thank you, Dr. Wali, for chipping in there. One question is, again, which has been answered by Ritesh, but I'm answering again. Which anti-hyperglycemic is the best? So forget about the theoretical concerns about anti-hyperglycemic drugs and just concentrate on metformin. That's all. Metformin is the best at this point of time. If patient doesn't have a diarrhea, vomiting, etc., please continue metformin till whatever time he's on intravenous drugs and so on. Because whatever data we have, although these are not robust data of a randomized control trial, but it seems metformin will decrease mortality in these patients. So my patient at this point of time say, well, doc, should I go on to insulin because I hear that is the best for COVID-19? I said, no. I say, metformin is the best. If you are on metformin, please continue. If your sugar is uncontrolled and I have some space to increase your metformin, I will do so. Please don't discontinue this metformin. That is the best drug. There is some controversy about ACE inhibitors still, despite Dr. Ritesh and Amrita explaining it. Now, what I want you to do is to forget all those pathways. Please forget the pathways. Just say it is like a seesaw. One pathway showing harm, other pathway showing benefit. So I feel at this point of time, the benefit part is up in the seesaw. And so patients should be told in no uncertain terms to continue with ACE inhibitors unless hypotension occurs. Now, there is another question about, just hold on. Another question which initially Preeti asked is about whether, hyperglycemia after exercise may cause problems in this situation. Preeti, hyperglycemia after exercise is well-known phenomena. That's because probably because of increase in the cortisol and adrenaline flow during exercise. And if it is for short time, it is not going to cause any problem because average sugar, if it's okay, we are going to be fine as far as that is concerned. Then Ritesh, one more question, and that is from Bangladesh. A middle-aged man with A1C of 7.4% develops mild to moderate COVID-19. He's on metformin, DPP-4 and SGLT2 inhibitors. What do you suggest regarding change in anti-diabetic medication? Will the scenario vary if he is hospitalized or not?
Yes, so that's a good question. As we discussed, I would probably stop SGLT2 inhibitors. He has mild to moderate COVID-19, and SGLT2 inhibitors will not be an ideal choice. Patient is prone to get dehydration and use glycemic ketosis, so we would stop that. We would continue with metformin and DPP-4 inhibitors. There is no evidence to suggest that they do any harm, and in fact, we have seen metformin has many theoretical benefits and some evidence of clinical benefit also. Unless the patient is not able to tolerate metformin, unless there is vomiting or very poor oral intake. And in that case, we'll need insulin. If the patient is hospitalized and has severe disease, definitely insulin. But if he can tolerate other drugs and he is taking orally and he's not on a ventilator, he's breathing normally, then of course we can continue with the oral drugs.
Okay, we have at least 20 more questions. Simi, are you there?
Yes, sir.
Simi, can you type out emails of Dr. Amrita, Dr. Ritesh, and mine in this, sure, so that they want certain questions answered, they want some diet charts and so on, and we can provide to them also. Last question before we log off is about hydroxychloroquine, and that has elicited at least 5 questions. Number one question, which is not often asked, is that it can cause retinopathy and what will happen to retina in this time. Hydroxychloroquine in the doses used for a short time is not likely to cause anything as far as retina is concerned, but longer time, yes, certainly. And to tell you frankly, nobody has looked at retina. That is the last in anybody's mind at this point of time, but that should be looked at. Somebody has said, at all whether hydroxychloroquine acts or not Well, that's still after all these trials, all these time, still a mute question. I frankly believe it does not work, and some people believe that it works, and that includes presidents and prime ministers also. So I can only give you a scientific overall overview, which Dr. Amrita has shown. Uh, I feel number one, it does not work as far as treatment is concerned in severe patients. Number two, whether it works as a prophylactic agent, I don't know, and that needs more study. So that's where we are. And Ritesh, there is Amrita, there is a question about diarrhea in COVID positive patients. You were showing a slide. Can you just quickly tell us?
Yeah. So diarrhea is caused due to many reasons, the same thing which I told, that ACE2 receptors and other things. And it is caused basically because of the cytokine pro-inflammatory markers and other things. So, proton pump inhibitor reduces the acid in the body, and that can also increase the expression of the ACE2, and it can cause diarrhea. Basically, this is all preliminary reports which has come because of the causes of diarrhea.
Thank you, Amrita. And last point uh, is uh, just hold on. There was one point I wanted to answer. Um, Yeah. Last point, Ritesh, was about steroids. So they say steroids, when is to be used according to evidence, and if it increases sugar, what is to be done? That is the last question.
I think the most important thing is not to use steroids in initial stages and in mild cases. So that would only increase viral replication. So only if the patient has moderate to severe disease, when you are suspecting a cytokine storm, then is the time to use steroids. Steroids are most likely to increase blood sugars, especially in this setting. And in that situation, one will need to use insulin. Because such a patient would anyway be in the hospital, and you can safely use insulin in such a patient to control sugars.
So what Ritesh is saying, most of your patient will not need steroid. Please don't start steroid when the fever occurs and so on, because it will do more harm than good. It should be only be given in patients who have low oxygen saturation, are on ventilator, and are fairly sick. And then the dexamethasone or methylprednisolone, whatever it is, that may be given, and certainly it will increase sugar, and that remains a problem, because then insulin resistance will be very, very high combined with the COVID infection and steroids. So sometimes it's difficult to control sugar, but if it's over a short period of time, we should use insulin infusion, a frequent insulin injection to tide over this crisis. So thank you all for joining in. We had a huge number of people who joined in, and we had 37 questions, 34 questions, uh, out of which 10 to 12 or 15 we have answered. The rest remained unanswered. And Simi, I'll hand over to you. Please share email, and they also wanted something else, e-certificate or something. So please respond.
Sure, sure, sure. Thank you so much. I think you all must have enjoyed the way, as a participant, I have enjoyed. I think we have to thank Dr. Anoop Misra, Dr. Ritesh Gupta, and Dr. Amrita Ghosh for the wonderful session, requesting all the participants to share your feedback. So we'll be sending you the email survey, which will be sent to you soon. Believe me, what went right, what went wrong, how can we improvise? So all your suggestions can help us shape our future events. We sincerely hope we have met your academic expectations. In terms of, the questions which are coming around the certificate, we will be giving all the participants who have taken out time from their schedule. So we will be sending them certificates for sure. I think I'll be soon sharing. We will get back to you with the email IDs of our faculty. so that all these questions which you have posted can be addressed timely. And I think I'd like to inform briefly to all the participants that BMJ, in partnership with CDoc Fortis under guidance of Dr. Anoop Misra, has come up with 6 months course in diabetes. This course is endorsed by Royal College of Physicians, London. Do visit our website, that's educationindia.bmj.com, or you can write us on marketingindia.bmj.com for any further queries. This brings to the end of this webinar, and before we conclude, I think we all will say that stay safe, God bless you all, and have a wonderful evening ahead. Thank you so much.